Right, so I've been asked to say, well, answer the question, what is TTP? But I've also been asked to talk about my first case of TTP. So I will talk about what TTP is, but my first case was over a quarter of a century ago, actually. And it was before we even knew what caused TTP. So it was someone in their 60s. They were admitted just generally unwell. They had a blood test done, and they had anemia and a low platelet count. But back in those days, blood tests were more unreliable. We used to take them in a syringe and then squirt them into the bottles, and sometimes it went wrong, and sometimes you got like odd platelet results. So we said, well, let's repeat it. We repeated it, and the platelet count was normal. So we all went to bed thinking this is fine. Apart from in the morning, I came and looked at the blood film, and the platelet count was low, and there were also these things called fragments. And this particular patient was getting more unwell. We explained we thought it was TTP. We don't know what causes it, but we know that plasma does seem to work. So when we look at your blood under the microscope, we look at red cells, these are these things, and we look at white cells, these gobble up bacteria, and we also look at platelets. That's a platelet up there, that little thing there is a platelet. So they're quite small. Fragments, red cell fragments. So that you saw those red cells were nice and round, but in TTP they get chopped into little pieces, and they actually get chopped into pieces that are not that dissimilar to the size of a platelet. And what had happened is we had this old machine that was used out of hours. So the second sample was taken in the evening, and they used an evening machine, and the evening machine had a technology that counted fragments as platelets and gave a fake high platelet count. So a bit disastrous. But this patient is a Jehovah's Witness. They would not accept blood products, just would not. Pre-signed advance directive, family confirmed absolutely they would not accept blood. So we had to talk to the hospital liaison group. These are people who support patients and doctors if they're Jehovah's Witnesses, and they had access to a lot of material, a lot of published material. This is before you could go on the internet and look things up. And said, well, there's been successful cases of use of vincristine, which is another treatment. We used that. We tried plasma exchange without plasma, just with water, basically. But unfortunately, it was unsuccessful. Now, as doctors, when things don't work, it can have a profound effect on our future careers. You can come away from something like this and think, I'm going to do everything in my power to make sure that the next time I see a patient like this, it'll be successful. So these cases are really important. They sort of form you. They make you. They give you an interest in what in your future career. But I'm going to go back to what is TTP, and it really depends on who you ask. So if you ask a hematologist, it is the ultimate emergency. I mean, often, I know some of you are my patients, and sorry if I'm very flippant, but when you look at it, it's like a duck on water. You see on the top maybe calm, but underneath the little, yeah. So it is probably the ultimate hematological emergency. You absolutely cannot waste a moment. You just got to get on. So that's what a hematologist thinks of TTP. What about your non-hematologist, your GP or your specialist, any specialist really? And you'll find this, no, they don't know what TTP is. And you may think, well, doctors should know everything. There's loads to know, right? That's the problem. There's too much to know. We can't know everything. And so you have to be patient with your doctors that are not hematologists, even some of the hematologists, to be honest. You can educate them. Because we can't know everything, and it's rare. It is rare. So be kind to us. Okay, we don't know everything. What about my local graffiti artist? So I live on this road. That's Barney's Barbers. I just live that way, and I saw these things appearing everywhere, and I thought Joe had been around just like with a tag. But it's that blooming terrorist organisation. And there's loads of these around where I live, but anyway. Yeah. If you type TTP on Google, it's the first thing that comes up. So, quick history lesson, okay? I like quotes, although my favourite quote is, everything has an end, apart from a sausage that has two ends. But But I'm going to take you back now. So it's nearly 100 years since the first case of TTP was described in a 16-year-old who presented with weakness and fever and some odd neurological problems. And they did have microscopes. They could see, look at the red cells, look at the platelets, saw the fragments, and saw that there were blood clots in the small blood vessels. And we actually didn't make a lot of progress, actually, for a long time after that. Let's say it's nearly 100 years since that first description. But then I'm taking you, I say, not much was learned after that until 1982, when we worked out that von Willebrand factor was something to do with it. Okay, so von Willebrand factor, it's a natural protein that helps you to clot. So if you cut yourself, von Willebrands will help you stop bleeding. And it circulates in these massive strings. And the bigger the string, the stickier it is. And if it's really big, it will stick platelets. Platelets will stick to the strings, and then they will clog up the blood vessels. And that is essentially TTP. It's all about sticky strings in your blood. We all make these sticky strings. And so the next thing is, we worked out, so we knew about the sticky strings. We didn't really know why the sticky strings were like that, but we knew that we had sticky strings. The next thing is we worked out that you could wash your blood. We could do blood washing. Plasma exchange. Take out your plasma, replace it with fresh plasma. And this was 1991 where it was published that plasma exchange basically was really very effective. It reduced the risk of death significantly. I mean, 85% survival in a disease that used to have 100% death rate. So we have sticky strings, and then we learnt we could wash your blood, and that would help. Hope you're following me. And then it gets really exciting. So you know, if you're doing you're asked to log on to something and you need a password and stuff, and it says, what's your memorable date? You know, you might say, oh, it's when my child was born, or when I got married, or got divorced, or whatever. And for me, it was 1998. I am a total nerd. Okay, 1998, they discovered this enzyme, ADAMTS13. They hadn't named it at that stage, but they knew it was an enzyme. It got named in 2001. So in 1998, they found it. They found an enzyme. What does that enzyme do? It cuts the sticky strings. So we all make the sticky strings, but we need this enzyme to regulate the length of the strings, to cut them into smaller pieces so they're less sticky. And it was the absence of that enzyme, ADAMTS13, that's the cause. So it was just, there was a Chinese paper and a Swiss paper at the same time in the same journal. It was amazing. We finally knew what we were dealing with. So I've talked, but I'm going to show you a video as well. This is on the website as well, just to sort of try and visualize it, I suppose. So this is thrombotic thrombocytopenia, TTP, acquired, as opposed to the one you're born with. This is the commoner one. So this is someone who's had an injury. If you have an injury, you need the sticky strings, and it binds platelets, and it plugs the hole. That's what happens in normal situations. Those strings aren't too long, they're just the right length. This is the ADAMTS13 enzyme, and it's cutting the strings into smaller pieces to make sure that the strings are not too long, that they're just right, you know, not too long, not too short. Short ones are rubbish as well. And so that's this enzyme that was discovered. But sometimes someone makes antibodies against the ADAMTS13. We make good antibodies to fight COVID and other infections, but sometimes we make bad antibodies. And these bad antibodies bind to the ADAMTS13 and stop them being able to make the strings smaller. And therefore you get spontaneous groupings of platelets and long strings that block your blood vessels, even in the absence of injury. So it's a normal process gone wrong, basically. And that, in essence, is TTP. And as red cells go through that clot, they get fragmented into little pieces, which is why we get fragments. So these clots can go anywhere, heart, brain, kidney. So that's a sort of visual of what I've said. So in terms of numbers, the blue is people making bad antibodies, the acquired form. The red is inherited. You can have a genetic deficiency of the ADAMTS13. You can see the blue is more common. There's a lot more blues than reds. So the more common type of TTP that most of you will have experienced will be the acquired, but I know some of you have had the congenital as well. So explaining treatment, we knew blood washing was good, but it appears that blood washing replaces the missing enzyme, the missing ADAMTS13. And it also helps to get rid of some of the bad antibodies as well. So it probably has two functions, the plasma exchange, getting rid of bad antibodies and putting in new ADAMTS13 enzyme. And we've got this new kid on the block, caplacizumab or Capla. And basically, that doesn't remove bad antibodies, and it doesn't get rid of the long, sticky strings. What it does do is stop platelets sticking onto the strings. So it's been an excellent additional therapy to what we have. It stops that platelet sticking to the string business. It gets in the way, stops that happening. In future, we might even get away without needing plasma exchange. I think so. So, in conclusion, I'm going to go through it now. We make sticky strings to stop us bleeding. We have to make those strings of von Willebrand's, otherwise we hemorrhage. But we control the strings with this enzyme called ADAMTS13. We don't have enough ADAMTS13, the blood gets sticky. Platelets stick to the strings, block our blood vessels. This can be dangerous and damage body organs, brain, kidney, heart. To treat TTP, we need to replace the ADAMTS13 that's missing and get rid of the bad antibodies. We can wash your blood, and we can get rid of the antibodies with steroids and rituximab and stop platelets sticking to the strings with Capla. So in essence, I hopefully have explained what is TTP. Just out of curiosity, I don't think we've got time for discussions, but I'd be curious to know, when did you first understand what TTP was? I mean, if you're unwell at the beginning, you're not in the right state to be taking in these things. I'm just curious to know when people first said, actually, now I get it. I now know what it is. Was it very soon after diagnosis, or was there a delay? Who explained it to you? And did they explain it well? When is the best time to go into details? I mean, when you first come in, you don't want someone like me talking to you about sticky strings and stuff. You just want to get on with treatment, don't you? And verbal information, written information, videos, again, I suppose my real question is, how, as medical professionals, could we do this better? Thank you.